My name is Kees Poelstra and I am a spine surgeon working in Destin and Fort Walton Beach, and I'm associated with Sacred Heart Hospital. Initially I did my medical school over in Holland, and I came over to Virginia for my PhD, which I accomplished between medical school and starting my residency in orthopedic surgery at UVA. And following my residency, I was so fortunate to work with Drs. Vaquero, Albert, Hillebrand, and Anderson, as well as with the neurosurgeons in Philadelphia, and I got a spine fellowship at Thomas Jefferson University. It is very important that surgeons understand the complications that can occur with instrumented spinal fusions. Most patients that undergo a single or two-level operation are typically okay, but as soon as there is a slight patient compromise with a comorbidity, as well as a larger invasive type procedure, patients are inherently at risk for becoming infected. And it seems now more and more research is being done on the invasiveness of the procedure, and even if we would operate on somebody who is in perfect health, if we do a large operation that compromises their immunity, there is a higher chance for them to get infected than when we do something smaller. When we started initially the infection research, it was interesting to me that there was no real implant infection model that mimicked a clinical scenario. And I think that's in part due to that a lot of models were designed by PhDs that were not surgeons. So the first thing that we did, starting our infection research, was to create an implant infection model that would mimic reality, where you would have a compromised site, you would have a dead space similar to after a large total joint replacements or large spine surgeries, and then you would be able to place a equivalent implant in there that we use in the human spine and in the human body with joint replacement, and then have an environment that would be similar to the challenges we face currently with patients undergoing implant-related surgery. MRSA is a special type of Staphylococcus bacteria. It's a gram-positive bacteria, but it has developed over time significant resistance to almost all antibiotics that we currently have. Two antibiotics that are still left to kill MRSA are typically vancomycin and gentamicin. To try to reduce the infection in patients that undergo larger type surgeries, patients sometimes receive a powdered antibiotic mixture inside of their wound, predominantly vancomycin powder, as the surgeons try to leave something in that wound, in the dead space they create after closing the wound, that would potentially help kill bacteria that inevitably fall inside of the wound during surgery. The problem with that is twofold. It's primarily that the delivery is simply in a powdered form, so the antibiotic is immediately available up to sometimes toxic levels. And the other problem is that there is no longevity of the release of the antibiotic. The antibiotic, as soon as it's out of the powder, it's gone, and there is nothing left in the wound, typically after 24 hours, that would help to kill the bacteria that are still sitting around, sometimes dormant, and they don't wake up for about 48 hours when there is time to infect the wound, since the therapeutic has already leached away. We perfected the rabbit spinal implant model. We were finally able to get the microspheres in that model and compared it to having no application of antibiotic, and it showed clearly that we were able to establish a solid infection rate of about 80% in all treated sites with just bacteria and no antibiotic. And then when the gentamicin microspheres were added to these sites, that we saw a significant reduction beyond 50%. In cases where you leave vancomycin powder behind with the beneficial effect potentially to reduce infection, you also create such a high amount of antibiotic in the wound that it can lead to a reduction in bone growth. So it defeats our purpose of getting the spine to solidly fuse. So that's another reason that I'm very careful with the antibiotic we apply in powder form to the wound, and I would look very much forward to the ability to use clinically these gentamicin microspheres for better choice of antibiotic and having long-term benefit of the antibiotic leaking from the microspheres while they resorb. There's no worse outcome of a complex surgical intervention than if it turns out to become an infection. So when patients typically come back after a week or 10 days and they have some slow healing of the wound, they have some purulent drainage, and we identify indeed that there is an infection going on and not just some superficial wound issue, patients' lives basically get turned around around completely. Initially, we give them as much as we can a realistic expectation that any type of spine surgery is not a walk in the park and that it takes some time to recover from it. But if patients truly develop a deep wound infection, it usually leads to multiple surgical interventions to wash out the wound, to get as much of the debris that is left there from the bacterial growth out of the wound. Most of the time they lose all of the bone graft that we so meticulously put in there to try to get the bone to fuse to each other, and often the hardware that we put in there to stabilize the spine needs to be replaced by hardware that is not coated with a biofilm, which is sort of a sugary layer that bacteria cover themselves up in on the top of the implant, and that leads to at least a few weeks of hospital stay in those patients' futures, and a completely different rehab and ability to get back to what they would like to do compared to what we initially set out to accomplish for them. So it is very difficult to give people a realistic expectation of what's happening after they get a wound infection, and it's one of the most daunting things that you face as a spine surgeon, having to put these people up in the hospital and delaying their return to work and play for sometimes months at a time. We talked before about complex spine surgery, which in itself is expensive already, but then if numerous surgical interventions need to be done after somebody comes back with an infection for which the hospital doesn't get paid, is a tremendous burden on sometimes the local community, where a small hospital simply tries to do the right thing by offering spine surgical services and total joint surgical services, but they almost go into the red from simply having 1 or 2 infections a year, because all of the payments need to be made by the hospital for the care of that patient. That includes both the surgical services, the anesthetic services, the hospital stay with the patient in bed or sometimes in the ICU, as well as all of the IV antibiotic medicines that need to be rendered to the patient during and after the hospital stay. Sometimes patients stay on a prophylactic antibiotic to suppress the bacteria for 6 months after the infection, and the hospital currently has to eat those costs. So that's an additional burden for society that needs to be alleviated.